This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I am one of the course directors for Cardiology and Critical Care Academy. I would like to introduce our speaker, Dr. David Weissman, who will demonstrate how to obtain optimal parasternal long axis images.
Point of care echocardiography. On this cartoon image of the heart and chest, you will notice the three important landmarks in echocardiography: the parasternal, apical, and subcostal. In today's lecture, we will be concentrating on the parasternal for the long and short axis and the subcostal view. The parasternal view is exceedingly important, primarily because there is a break in the lung and we have direct access to the heart without having to transverse through air. You will notice that we will be using the phased array probe. The advantage of the phased array probe in echocardiography is its small footprint, thereby giving us an opportunity to access the heart through the intercostal spaces. Also, the phased array probe is a low frequency probe, which allows us to get several centimeters deep so we can view the heart in its entirety. The parasternal viewing spot is extremely important as we do obtain two important views, the parasternal long and short axis from this viewing point. The ideal location tends to be anywhere between the second to fifth intercostal space. I typically will go down the patient's intercostal spaces one at a time, and it's typically the first or second spaces, which is your most ideal space to work with to optimize a nice image. The subcostal view is visualized here, and this is accessed through the abdomen. The ultrasound beams are directed towards the heart. They will transverse through the liver, and we are able to obtain beautiful views of the heart from the subcostal view. This is an important view as many of our patients may be hyperventilated or on ventilators, making it a bit more challenging to get quality parasternal images, and often subcostal images can be quite useful. Also, it is very helpful for ruling out pericardial effusions. The parasternal long axis view of the heart. Here we have a patient who's lying supine on the table. You'll notice the ultrasound technician is holding a probe in their right hand. This is the probe marker pointing to the patient's right shoulder. If we think of the chest as a clock, with the sternal notch being the 12 o'clock position, this probe will be pointing to the 10 o'clock position. This is to the right shoulder. You will notice that the probe is just lateral to the left side of the sternum. The examiner marched their way down the parasternum until they found an optimal viewing point, and typically it's that first or second viewing point which is the optimal place to start your scanning and image acquisition. Typically this is between the second to fifth intercostal space. The image will be slicing the heart as is seen in this cartoon image. It would be extremely helpful if you have access to a 3D model, thereby allowing you to better visualize the images on the screen if you are able to obtain a 3D model that allows for a parasternal long axis cut. This is a typical image of the parasternal long axis. Here visualized is the right ventricular outflow tract, which is also seen in this cartoon image here. We will look at the aorta next, sitting here, and the left atrium sitting right here. We call this the three chambers: the left atrium, aorta, and right ventricular outflow tract. Just a bit deeper to the right ventricular outflow tract is the septum of the heart. Here is the left ventricular outflow tract, pictured here. The aortic valve separates the outflow tract from the aorta, pictured here on the ultrasound image. The LV cavity encompasses the entire space from the inferior lateral wall, seen here, to the septum. This is the LV cavity. You will notice the mitral valve has an anterior and a posterior leaflet. The posterior leaflet is smaller than the anterior leaflet. The anterior leaflet will be extremely helpful as we start talking about overall LV function. The inferior lateral wall is pictured here. Often we will notice chordae and papillary muscles, and the bright pericardium is pictured here. Again, this is emphasizing the different walls, the anterior septal wall and the inferior lateral wall. We will once again identify the structures seen in this image. Here we have the right ventricular outflow tract. This is the right ventricular wall. This is the septum. This is the aorta. We will in a moment see the movement of the aortic valve pictured here. We will look at the left ventricular outflow, the LV cavity, the inferior lateral wall of the left ventricle, the bright pericardium. And a very important landmark is this. This is the descending aorta. And typically, you like to see the descending aorta to make sure you are at the optimal depth for the patient. We are also visualizing the posterior leaflet of the mitral valve and the anterior leaflet of the mitral valve. Let's play this clip and identify structures once again. Here we see the parasternal long axis in real-time motion. Once again, we will visualize structures. Here is the right ventricular outflow. This is the aorta, the aortic valve opening here, the septum of the heart, the mitral valve pictured here, the anterior leaflet and the posterior leaflet, the LV cavity in between the septum and the inferior lateral wall, the bright pericardium, which wraps around the heart, and the descending aorta. Finally, the left atrium. On this next slide of the parasternal long axis, we're going to focus ourselves on two important concepts to help assess patients at the point of care. One is called the rule of three, and the second will be a discussion about determination of LV systolic function. First, let's talk about the rules of three. If we point our attention towards the right side of the screen where we're looking at three chambers, the right ventricular outflow tract, the aorta, and the left atrium. These three chambers should line up, and they should also be about the same diameter and size. Normal size of the diameter of these three chambers is 2 centimeters. So if one of the chambers is larger than the other, that may point us in the direction of a problem. For example, if we have a patient that comes into the emergency room who is acutely short of breath, and we do a parasternal long axis of the heart, and we determine that the right ventricular outflow is much larger than the aorta and the left atrium, I'm going to point my attention towards that end. Something on the right side of the heart may be causing the patient's symptoms. Likewise, the left atrium is a wonderful surrogate for high end diastolic filling pressures of the left ventricle. Therefore, often it can be used as a surrogate for heart failure. It may not differentiate systolic versus diastolic heart failure, but it does tell us that the left atrium has been under stress under a period of time due to high end diastolic filling pressures of the left ventricle. That is the rule of three. Second, I'd like to turn your attention to determination of LV function. There are three main determinants of LV function in the parasternal long axis view. Two are systolic signs and one is a diastolic sign. We're going to start with the two systolic signs. The first is endomyocardial excursion. You will notice when the heart contracts, the cavity of the left ventricle shrinks. This is because the ejection fraction of 60% will be ejected from the left ventricle during systole. Therefore, the blood containing oxygen will be able to move around the body. And in order to do that, the cavity would have to shrink by 30%. So typically, this is a eyeball sort of assessment. We could certainly take measurements of the left ventricular cavity, both during systole and the diastole, and make comparisons. But the point of this is really to make quick assessments at the point of care for our patients. So a 30% reduction in the cavity size would be normal endomyocardial excursion. I usually tell students and residents to put their finger towards the lateral part of the left ventricle seen in the image, and the wall should be coming towards your finger. Also, myocardial thickening is the second sign that we'll see in evaluating left ventricular function. And the myocardium should thicken by 30% or more. And you can see the thickening in the infralateral wall and the septal wall. And again, this is an eyeball sort of view looking for a 30% increase in the thickness of the myocardium during systole. Finally, the last is a diastolic component called the E-point septal separation, and is looking at the septal motion of the anterior leaflet during diastole. So the left ventricular's function is to move blood around the body, and to do so, it must fill up with each cycle. So it wants nothing more than to move blood from the left atrium into the left ventricle, at which point it can eject it out during systole. So during diastole, when the anterior leaflet is opened, it must open nice and wide to allow that blood to move freely from the left atrium into the left ventricle. So the ER docs, our colleagues, call it the slap sign, where the anterior leaflet should just about slap the septum. Typically, it should become within 7 millimeters. I always tell resident students to use over a centimeter. If there's a distance between the anterior leaflet and the septum of a centimeter or more, you certainly have LV systolic dysfunction.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.